Welcome to our Obesity Care Week Congressional Briefing, Obesity Policy Update, Time to Commit to Care. I'm Joe Naglowski, OAC's President and CEO, and I'm so excited you're joining us today. OAC is this year celebrating our 20th anniversary of advocating on behalf of people with obesity. We were created all those years ago after a legislator stood up at a briefing, not unlike this one, and actually asked the question, who represents those affected by obesity? That legislator said I'm asked pretty much every single day by a healthcare professional or by a public health official to uh, do something about obesity, but I actually never heard from people with obesity themselves. And so that's what OAC is. That's the work that we do. And our work has been fulfilled on that mission for the last 20 years as we've grown to nearly 100,000 people living with obesity. We support each other seeking better health and good quality of care. And we do so throughout the year on all kinds of activities, but especially this week as we celebrate Obesity Care Week. Today is the first day of Obesity Care Week, our annual public awareness campaign with a vision to create a society that understands, respects, and accepts the complexities of obesity and values science and clinically based care. Obesity Care Week, which we were a founding champion of, is supported by more than 160 champion organizations and leaders in countries throughout the world. And as part of Obesity Care Week, tomorrow, we will actually celebrate World Obesity Day. Throughout my 20 years at OAC, the fight for access to care has been our most significant struggle. Every day, people call our helpline or reach out to us across email or social media and share their experiences being denied access to care, to evidence-based treatments for obesity. We've seen some progress around access to intensive behavioral therapy in some environments and to bariatric surgery, but we still have a long way to go, especially in Medicare, where obesity medications are by policy excluded today. This fight and our need to commit to care is the theme of our policy briefing today. I'm pleased to be joined by an excellent panel who share their expertise, including, hopefully, Parker Reynolds, the Senior Health Policy Advisor to Senator Dr. Bill Cassidy, one of our longtime supporters of access to care in both his House and Senate careers. Dr. Renee Hilton, a bariatric surgeon from Augusta, Georgia, and a champion for access to care, leading the American Society of Metabolic and Bariatric Surgery's Access to Care Committee, and Miss Nikki Massey, who was just elected chairperson of the Obesity Action Coalition's board of directors, and will take that essential role that legislator asked us to do all those years ago and be the voice of someone living with obesity. So with that, I'm going to ask Dr. Hilton to kick us off. Welcome, Dr. Hilton.
Thank you very much, Joe. Can you hear me okay?
Sound great. Thank you.
Excellent, excellent. So I think first, just to introduce myself, I'm also a person living with obesity and have benefited from the treatment of obesity. I'm also a surgeon and physician treating this disease. So I think the first thing to acknowledge about obesity is that it really picks no favorites, chooses no classes. It affects all of us, and it really is a pervasive disease. So I'm incredibly happy that we are doing weeks like this to make more people aware and to fight for patients to have access. I am the current Access to Care chair for the ASMBS. So I like to joke that I'm the squawk box of the ASMBS because I think I'm where every email about access or insurance or questions that patients may have about obesity, I tend to be the filter for most of those. And so I think it's a really important role because it puts me in a place where I see our patient concerns and our physician concerns from all 50 states in this country, which is unique because prior I've been dealing mostly with Georgia. Now I get to see across the nation what access to care problems we're still having, which are a lot. But I really wanted to focus first, as Joe has tasked me, on actually the science of obesity and why obesity is a disease, because we know we have access problems. But the first question is obesity a disease? Because I think if you walked out onto the street today and you asked 10 people, is obesity a disease? You're going to get a variety of answers, but the most common is probably going to be, no, it's not a disease. It's not cancer. This is something that patients do to themselves because they're not exercising, or they're not eating, or they are eating and they're eating way too much. And it tends to be a disease where the patient is always blamed for bringing the disease onto themselves. And we know with current science and with evidence, that is just not the case. The American Medical Association, the AMA, the House of Medicine, the defining authority of medicine, has defined obesity as a disease, just like diabetes or hypertension or cancer, since 2013. And that's when the House of Medicine did it. But when you look back at history, I mean, we have Hippocrates himself more than 2,500 years ago saying obesity is a disease that affects other organ systems. The British physician Thomas Sydenham in the 1600s made note that obesity is not only a disease, but it is a disease that widely affects the rest of the body. And so I think that probably the biggest breakthrough that we will have as everyone caring about this disease is when the rest of the world, those not educated in it, understands that this is a disease. It's not something that patients bring about themselves. My patients are not lazy. They are not overeating. I have many patients that are working out 2 and 3 times today. They are on a 1,200 calorie caloric deficit diet. I mean, they are working so hard. Yet, despite doing all of the things right, listening to everything I'm saying, this disease is multifactorial. It's incredibly complex, and they not only cannot lose weight, but they continue to gain weight. And a lot of that is because of the science of obesity. Once you have obesity, once you have that systemic inflammation, rising in cortisol, increase in estrogen for women or other hormones, this systemic cycle that just perpetuates itself with further insulin resistance and further, inflammation, it gets harder and harder to lose weight. So you may be doing everything right, but it's not your fault. And we know that we see this, that it runs in families. There is definitely a genetic component to obesity. And then there's also just life happening. Maybe you go through changes. Maybe you have a debilitating disease, or you get cancer and have to go through chemotherapy, or you are, a woman and you have a baby and you gain weight from that. It's hard sometimes to get your body back to that baseline step, but we know that this is a disease, and that is really where we have to continue, I think, the education process, because once you have defined obesity as a disease, to me, all of our access to care issues should have ended, yet they have not. And what do I mean by that? If you look at other diseases, if you look at diseases such as cancer or even diabetes, diabetes might actually be one of the best examples to compare to. When a patient is diagnosed with these things, cost is often not taken into the picture. Even if the treatment is really expensive, these patients have access to the medication. Even if it is kind of cost prohibitive for our society or for the insurance company, because it is the right thing to do to care for patients, to prescribe them treatment for their medical disease. Yet obesity is not given that same consideration. So when we look right now, Joe's already kind of alluded to medications for treatment of obesity. You have medications that are the exact same drug. One treats diabetes and one treats obesity, covered or not covered by the exact same policies for the exact same patient. I cannot prescribe them a medication for their obesity, but if I can somehow label them as having diabetes, I say diabetes because that to me it's probably its own condition. I can all of a sudden prescribe them this medication. And to me, that is the most flagrantly accepted discrimination and bias that we probably have in today's healthcare system. We just tell these patients, we're sorry, this is an elective thing, or, you're not going to get this medication because it's for obesity, and we don't cover that. I do not know why we continue to allow insurance companies or providers or anyone to stand between us and our patients and say you cannot treat their medical disease, because that is what obesity is. The other thing about obesity that I wish I could shout from the mountaintops in terms of making policy changes and insurance changes to cover this is that when you treat a patient's obesity, as much as I hate to bring return on investment into it because it's all about cost, all of this is about money, or we wouldn't still be talking about it. When you treat a patient's obesity, you're not just treating their obesity, you're treating 65 other medical problems that we know are directly related to obesity, caused by it, made worse by it. you are preventing more than 14 different types of cancer from occurring. It just is heartbreaking as a surgeon and as a person who prescribes these medications to be told that I cannot prescribe them the medication that will prevent them from developing this chronic disease. But once they get that chronic disease, you can treat it. And to me, it's just lunacy. It's repeating the same process over and over again. We know that these patients are going to do better if we treat them. I think another example that I often use when talking about the disease of obesity and how it affects our society is when you start looking at things like cancer. And if you look at the most common demographic who tends to get obesity, we tend to see it a little bit more commonly in women. Certainly, I'm a surgeon, so I typically operate more on women with obesity. When we look at things like endometrial cancer, the risk of a woman with obesity developing endometrial cancer and dying from that disease is over 6 times higher than other women in our population. I've taken women to the operating room with our OB/GYNs and done hysterectomies for uterine cancer, and yet not been allowed to provide them with bariatric surgery, which would not only have prevented them from getting it if we could have gotten to them earlier, but it also would decrease their risk of death having the disease. It would decrease their risk of recurrence. But yet it's not covered. They'll pay for the hysterectomy, but they still would not pay for me to do the operation to guarantee disease-free interval at the same time. And those are the types of things where I really see are kind of around the science of obesity that I just don't think people understand yet. And again, I know that this disease is costly to treat, but so are a lot of other diseases. There are many other diseases that are incredibly expensive to treat. Yet I think when you start talking about access, that's the reason it's not being allowed. And I get asked all the time or told all the time, oh, well, access to bariatric surgery is really great. Like 90% of Americans have access to metabolic surgery. And that may be true, but what kind of access do they have? Are there hoops? And yes, I could say, you know what, Joe, Nikki, Parker, you guys have bariatric surgery benefits. However, we're not going to let you get those benefits until you demonstrate 12 months in an intensive program. We're not going to pay for it. You're going to have to pay out of pocket for some of these. And then when you do get bariatric surgery, you're going to have to pay a higher premium to get that operation than you would say if you were getting an operation for a joint, a hernia, or cancer. So while they may have access, they truly do not have equal access to treatment of this disease. And to me, when I define the term access to care for treatment of obesity, it is all things used to treat that disease. It is access to surgery, it's access to medication, it's access to behavioral therapy, it's everything. We don't just treat cancer with radiation or chemotherapy or an operation. We do neoadjuvant therapy with medication, radiation. We then do the operation, and then afterwards we give them additional adjuvant therapy. Right now, we are so handicapped as providers trying to take care of this disease because I can only take care of this disease how the insurance company tells me I can take care of it. I have to check and see, well, do they have medical coverage? Do they have surgical coverage? Well, how long do they get this coverage, or what piece of it can I give them? When I know as a physician taking care of this disease, if I have a patient coming into my office with severe obesity, they need everything. They need all of it kind of rolled up as one package. And I think the last piece that I want to address, Joe, before I turn it over to the next person is improving utilization for our patients. A lot of our patients have access to care for this disease, yet we talk about only 1 to 1.5% of the population using bariatric surgery. I joke, I have access to my Peloton. It's upstairs in my workout room. My utilization is poor. I don't utilize it. I don't go up there and get on that bike every day, even though I probably should. I think getting it out there to the public that they have a disease and they have a lot of treatment options for it, to access their insurance that they have and utilize that benefit. At least come in and have a consultation and talk to your physician and see what benefits that you have available, because it's a complex disease and we really need to be taking advantage of all of our treatment options that we have together. So I'll stop there. I know we're going to have a panel later, but hopefully you can feel my passion through the screen, because I feel like I talk about this all the time, yet despite talking about it for 10 years, the needle is not moving as fast or as far as I want it to move. So thank you for everyone being here today to discuss it.
Thanks, Dr. Hilton. Really appreciate you sharing those remarks. And I'm going to turn it over to OEC's board chairperson, Nikki Massey, to kind of share her lived experience of kind of working through that system that you just described. So Nikki, the floor is yours.
Thank you so much. And Dr. Houghton, I really appreciated several parts of your remark. First of all, about the fact that we don't have this basic agreement that obesity is a disease. And then also, as you were speaking, I was thinking about the theme of this week, commit to care, because I'm here to represent sort of the lived experience, the patient experience with obesity. And in several points of my story, you can see like I was committing to care, but care committing to me, for lack of a better way of saying it. As I sit here, I have struggled with weight my entire life. I was actually born higher weight than folks expected me to be for when I was born. I struggled with weight throughout my childhood, throughout my adolescence. In my childhood, my parents, of course, did, the things that they thought that they were supposed to do. Uh, I grew up in the 80s, so diet culture was sort of at its peak then. So I was put on many diets and things like that, encouraged to exercise more. None of that really moved the needle in terms of managing my weight. I don't recall that weight management being a prominent part of my actual medical care as I was a child growing into adolescence. It was always something that we discussed sort of at home, and we already know that family can be the biggest source of stigma and bias for some of us. And I would say that even though my family was well-intentioned, that was the case for me as well, as I got a lot of comments at home, at family gatherings about my weight, but not necessarily any sort of evidence-backed plan to do anything about it. When I was in my early 30s, just after I had had children, I decided to undergo bariatric surgery. I didn't at the time have any what we call comorbidities. I didn't have diabetes. I didn't have high blood pressure. I didn't have all of that, but I did have quality of life problems. I had these two little children. I couldn't really keep up with them the way I wanted to keep up with them. And I wanted to be healthy into the future. And so, there's this sort of thread running in the back of my head about how women in my family don't really live long lives. I wanted to sort of improve my chances. I want to be around for my children and my great grandchildren. So that was sort of my catalyst. And, when I went into treatment for obesity, it's interesting because it is very much treated like it's on me. It's, this is a thing that happened to me because of my behavior, because of the choices that I made. So for example, even going into that initial sort of meeting with the surgeon, at the time that I had surgery, you had to get a referral through a primary care physician. And what people don't think about is, okay, well, maybe, that was what people did at the time, but it also required having or finding a primary care physician who believed in obesity treatment. I did not at the time that I started this. I had a doctor who very much believed if I ate less and moved more, I'd be fine. I didn't need any additional intervention. I did thankfully find a primary care physician who believed in obesity management and was able to get a referral to a surgeon. Once I got the referral to the surgeon, of course, the insurance companies come in and they want you to do, namely, a couple things. One is that you sort of have to prove that you're ready for the surgery by doing some form of diet, exercise, weight loss. And then two is like sort of this psychological evaluation sort of process that you go through. At the time, I didn't think that there was anything abnormal about that because I exhibited a lot of bias toward myself in that process. So I never really felt called upon to question, like, why is it that I'm being asked to do these things? I also had not ever dealt with the medical community in the form of like sort of having another condition that needed to be treated sort of in the same way. So I didn't really ask questions. I pushed forward. I got my surgery. I did have a lot of success with bariatric surgery at first. The interesting part about the bariatric surgery, though, is that once I got to like sort of about the 18 to 24-month mark, I had experienced a lot of weight loss and a lot of improvement in the things that I wanted to improve. But I did notice that from that point forward, the care specifically related to my obesity and specifically related to me as a bariatric patient started to become more and more infrequent. The surgeon's office that I went to didn't really see people more than a few years out from surgery. My primary care physician, who was aware that I had gotten surgery, wasn't always the most well informed about how the body that I live in after bariatric surgery works versus how it did before. So certain things just were on me, again, on me to advocate for myself. So I had to become very well versed in, not to give a shout out to the OAC, but shout out to the OAC, because some of the things that I know were supposed to be happening were I knew because of the education provided by the OAC. But things like, certain deficiencies that we would have to monitor for, and certain routine tests that I should be getting that my doctor didn't know very much about, and I wasn't being cared for by my bariatric surgeon any longer. Right now, I'm 17 years post-op. I don't have a lot of contact with obesity doctors unless I initiate it. It's not a standard part of my care. It's not something that people tend to ask me about. My primary care physician doesn't tend to ask me about it super often. I think that all goes back to obesity is an uncomfortable thing to talk about because we don't consider it, like, really in our heads a medical condition. We consider it being something like that gets at the person. And really, when you're talking about it as a medical condition, we should be able to have a open and honest conversation with our medical providers about it. So in my life, I contrast that with, back in 2016, I was actually diagnosed with a very early stage of breast cancer. And that's where, like, sort of these differences in how different diseases are treated really sort of became very, very obvious to me because, first and foremost, there was, I recognized that there was something wrong, and I went to go and have a conversation with my doctor about it. Wasn't an uncomfortable conversation. There was something going on with one of my breasts, and I talked to my doctor about it, and that seemed very normal, whereas it seems very uncomfortable to go in with the express purpose of talking about your weight. There were tests that were run. When the tests started to show that there might be something going on, there was a path that I followed. There was a special doctor that I went to see. That doctor had support services to make sure that I was getting all of the tests that I needed to get, that I knew the results of those tests, that I knew the steps along the path. Eventually, and without going into too much detail, it wasn't a straight path to diagnosis for the breast cancer for me, because thankfully we had caught it really early, and cancer can be a little bit hard to find when it's in its early stages. But once that diagnosis happened, I had options, and those options were supported by everybody on my medical team. Everybody was well versed in them. They could tell me, like, if you pick option A, here are the things that are very likely to happen. If you pick option B, here are the things that are very likely to happen. But most of all, I noticed how invested everybody was in keeping me in the process of getting treatment. So nobody made me prove that I was worthy of being treated of breast cancer. Nobody made me prove that I could handle whatever treatment options that I could get. It was more about me understanding what was available and the impacts that it would have on me, more so than whether or not I would be able to keep up with whatever the treatment was. I did opt to have a bilateral mastectomy as a result of that, and the process since then has been very different from my obesity as well. I see my breast doctor every single year. The first few years, I saw that provider a little bit more often than that. But so there's this pathway, and anytime anything changes in my care, I'm told what's changing and why. So, when we went from seeing that particular breast surgeon, a couple of times a year to once a year, I found out why and what the plan was going to be. I very much feel like when it comes to obesity care, like I said, if I don't know what I don't know, I'm not a doctor, I'm a lay person. And so, I don't always know what's the right next step. And there's no sort of central agreement within medicine that, okay, this person has this health problem, and here's the way that we should approach, diagnosing, treating, maintaining this patient. Instead, it's been a lot of, like, sort of, I'll find out new information, I'll ask my doctor about it. Again, it all depends on what my doctor's attitude towards obesity is, whether or not I get information that moves me forward, or whether I have to, sort of make a case for my own care, and advocating for really just sort of simple things that happen in other disease states that don't happen with obesity. And so, if you think about me, I think we could all agree I'm probably a little bit more engaged in this whole world than the average person. But if you think about the average person trying to go through that, not knowing what they don't know, not being a medical professional, and then also, really dealing with that stigma that we exhibit towards ourselves and that the whole of society sort of exhibits towards people of size, and then expecting them to push through all of that to get treatment. I think that, that sort of speaks to Dr. Hilton's note about utilization of treatment. You're asking people to go through a lot in order to treat their health. And it's not what you're asking other people of other disease states to do. And so I think that, when you start to just look at how, a person with obesity lives and moves through the medical community and their own treatment, you begin to understand some of the statistics that are out there as well.
Thank you so very much, Nikki, for sharing your story. We're going to shift to policy now, and I'm going to start off and share a little bit of history and some data, and then I'm going to ask Parker to jump in and share some of the reality that we're living with in Washington, D.C. now. So I did want to remind folks that this fight for access to care is not new. And by the way, it's not obviously only about these new medications, right, kind of thing. We've been fighting for, again, all evidence-based treatment options for a long time. And we actually started this fight more than a decade ago, working with now retired Senator Carper and Dr. Cassidy, when at that time was in the House. We introduced the Treat and Reduce Obesity Act, which we fondly call TROA, which helped expand the arsenal of tools, or would help expand the arsenal of tools available under Medicare, including both counseling and medication coverage. It's important to remember that at that time, the thought of medicines for obesity was a bit of a fledgling idea. We hadn't had a new medication in obesity in more than a decade, and of course had some past bad history in this space as well. But of course, if you fast forward to today, obviously you can see the vision of our original champions, Mr. Carper and Dr. Cassidy, because of where we are today. At the same time, we've also always pushed the regulatory side of this as well to get CMS to consider rulemaking changes. And we did that through the Obama, Trump, and Biden administrations. And we continue that fight through numerous Congresses, right? And we made the most progress ever last year when the House Ways and Means Committee marked up a limited version of TROA, showing meaningful progress. And then, of course, we were pleasantly surprised at the end of 2024 when the outgoing Biden administration, through CMS, proposed a rule that would expand access to obesity medications for both Medicare and Medicaid, leading us to where we are today as that rulemaking process is continuing. Worth acknowledging what Medicare does, private insurers typically follow. And you can see right now on the slide that I'm sharing right now, where we currently stand with access to obesity medication specifically. This database, which is the leverage database, which is provided through the Robert Wood Johnson Foundation, is one of the best sources of current data we have around obesity care, and exceeds basically 80% of people's healthcare coverage is included in this database. So it's a good way for us to take a snapshot, although obviously this coverage changes on almost a daily basis, so it is not perfect, so keep that in mind. So if you look at this first slide that I'm sharing with you here, this is the prevalence of coverage of obesity care. And you see the darker your state is, the less coverage that you likely have. And so ultimately probably slightly less than a quarter of people have access to obesity medications currently. And I'll use myself and OAC as the main example. So we are based in Florida. You can see how dark our state looks there. And I will tell you right now, for no amount of money can I buy health insurance that includes obesity care, either as an individual or as OAC, as a company, can buy that in the state of Florida as a small business. So the reality is that coverage of medications is pretty poor across the United States. And as mentioned by Dr. Hilton in her opening remarks, if you do have coverage in many of these cases, there are quite a few of hoops and hurdles that people have to jump through. And in fact, some people may not have access to the newest medications, even if they're listed as covered here on this slide. Moving to the next slide, we'll take a look at our Medicaid coverage, and you can see we have, about a third of states that are starting to cover obesity medicines under Medicaid. So there's been some progress in this area, and a lot of our advocacy work at the state level has been focused on Medicaid as well as state employees to try to gain access to this coverage. But again, I want to be very clear here. In many places, there are lots of hoops and hurdles to jump through. And in a few of these places, such coverage is under attack or under threat because of concerns over cost. And then finally, let's look at Medicare and let's look at Medicare. So this is where the area we're working in. So as you see here, the number says 0, maybe a slight exaggeration to the negative, because there are a handful of Medicare Advantage plans that might cover obesity medicines, or at least we hear of those occasionally. I'm not so sure we've actually seen evidence of that. So if anyone has that, please feel free to share that with us. But I think it's worth also acknowledging here that we did see a change this past year under Medicare as well, that there are some rare circumstances where some obesity medicines are covered if you have, for example, a specific comorbidity. So if you are on, for example, semaglutide might be covered if you've had a previous heart attack or a previous stroke. And then just recently, tirzepatide got the indication added around sleep apnea. So if you have moderate to severe sleep apnea, tirzepatide might be covered under Medicare. But the reality is that coverage is not great under Medicare, and it's extremely poor. And the reality is this is a population we need to take care of. And obviously, this has been the main thrust of our advocacy work moving forward. And by the way, going on to the next slide, it is not just OAC and those of us in the obesity community who actually want these medications covered. You actually see some data collected recently by the Obesity Care Advocacy Network, which is a coalition that we at OAC helped start many years ago that includes over 40 different groups working on these issues, trying to prove access to evidence-based care. And you actually see that you hear from this data that the public actually thinks it is important that Medicare cover these medicines to help people manage their weight and improve their overall health. In fact, over 78% of people think so. And then looking at the next slide, when we ask specifically around the Trump administration finalizing a proposed policy that would expand access to Medicare coverage of obesity medicines, you see this wide level of support as well. So over 71% of people. And so, with this broad support, it really is time for access to care to obesity treatments to become the standard benefit. That's our message today. And we'll talk to you about a call to action at the end, how you can help support that. But with that, Parker, I gave the brief history there and looking at that, but I'm curious if you want to share your perspective from your seat working with Dr. Cassidy.
Yeah, thanks, Joe. I appreciate it. Honestly, you covered a lot of what I was going to talk about, with kind of just the legislative history. The Senator Cassidy has been leading on this issue since he was in the House. And so it's been, something that's been really important to him. And it's kind of, playing out, and I think, vindicating him in terms of his view 10 years ago, just given where we are with the new class of drugs and, the effect that it has not just on obesity directly, but also kind of the indirect benefits of treating obesity and what that means for other conditions. So, we've been kind of happy to see over the years what this has done for, overall health for Americans. You kind of touched on a little bit. We were very happy with CMS's decision last year to include coverage in the Medicare and Medicaid space that essentially did, 85% of what TROA wanted to do. Unfortunately, we still would have, a lot of people I think forget in TROA, y'all probably don't, but most people we talk to do, which is there's the two components of TROA, right? There is the drug side, which is, pretty much what everybody thinks of when they think of TROA. But what was not included in the CMS rule, which we would still advocate for and continue to push for, is the Part B coverage to increase or to allow access to behavioral therapy and other treatments. Once folks are on the medication, that's great, but we really see the full the full power and the full effect of the drug when you do other behavioral lifestyle changes in addition to just taking the drugs. You can lose a certain amount, but it really, when you combine it with better nutrition, with behavioral therapy, with other options, you can really impact a lot of lives. a big challenge for us, and before the rule, was the CBO score that came out that said that coverage of GLP-1s in Medicare alone, not even in Medicaid, but in Medicare alone, would be somewhere between 35 to 45 billion dollars. That's a huge number, no matter how you look at it, but it's especially difficult these days because you have so few offsets. And so anything that Congress does, if you want to spend money on something like that, you essentially need to find some type of offset to pay for it. And until we saw the coverage rule come out of CMS, that was really going to be impossible to do full TROA. Obviously, as you mentioned, Joe, the House did pass a scaled back version of TROA, which probably would have been a couple $2 billion, which we still would have had to find the money for, but I feel confident we probably could have. Moving forward, I think kind of the two big decisions are going to be we need CMS to finalize the rule, because once CMS finalizes the rule, CBO will put that into their current baseline, which means that if you pass coverage of those drugs after CMS has said they're already going to cover it anyway through the regulatory process, it would reduce the score of TROA to nearly zero. So we would still need to codify that, but we would also need to find a way to cover whatever the cost would be to pay for the Part B coverage, which was not included. We have not gotten a CBO score for what that would be, but we hope it would be a pretty manageable number. So I think that is our hope, at least up here, is if we can move on those two components, we think that we can get TROA passed at a relatively small cost. And so that is what we are continuing to engage with the administration. We are continuing to engage with colleagues up here to work with the committees to keep advancing it. That is the goal when you're in Congress, right? It's very rare that you're able to move something in one big step. It's a lot more of a I think realistic proposition to kind of do what we're doing, which is just continuing to move the ball forward incrementally and kind of get the progress built Congress after Congress after Congress. And we've seen that in the list of members who've co-sponsored the legislation. We've seen that in again, the markup was a historic markup last Congress, even though it was not the full TROA bill, which we've been pushing for years. It was still a great step forward, and it means that is now on the radar of folks up here in Congress. And it means that committees are having the conversation about how to address the issue. So, I think that we can, honestly say this is we've never been closer to achieving in Medicare and Medicaid coverage of these drugs, as well as the Part B coverage, than we've ever been at any point since introduction of the bill. So, we're very excited. The senator's happy to be leading the bill. This Congress and the Senate, we're still trying to figure out which Democrat will join us, but we kind of see the horizon for the first time, that I can remember since I started working on the issue. So really excited to join with you guys and to have this conversation and to answer any questions from a legislative perspective.
Thanks, Parker. Really do appreciate that. And just to be clear, ideal situation is the administration adopts the proposed rule, then we immediately have to go back, but we're not done, right? Then we immediately have to go back to work and actually pass TROA, right? Because to your point, it has to be codified, right, to then avoid any legal challenges or a future administration changing that. So am I describing that correctly? So.
You are describing that right, and there are options that we could have around that to make that work.
Right. And then one more question for you, and then I'll ask some questions. And I would invite folks, if they have questions, to put those into the Q&A, and I'll take a peek at that as well. But I think we've asked you this before, but on this call you have a series of advocates and lots of people watching, and future folks will watch this. And what advice do you have for us advocates? Like, where should we be applying pressure now? Who should we be talking to? Any advice you have for us? So.
Yeah, I mean, I think that I'm trying to remember if the comment period for the rule is still open or not. I'd have to go back.
It's closed now, so yeah.
Okay, then yeah, I would talk to your members of Congress, right? I mean, that we're going to be the ones who are continuing to have conversations with the admin. We're going to be the ones that are going to have to vote on, potentially moving forward with this. And so I think it's important to let your representatives know that this is an important issue for you, and this is something that you think is a worthwhile policy that should be implemented. And then, depending on how it goes, we can always go back and revisit who the person is to talk with, or who the people are to talk with. But right now, I would just talk with your members and let them know that this is a priority for you.
Thanks for that. I appreciate it. Dr. Hilton, I know you spoke very passionately about access. So I'm curious, everyday barriers, like when folks, someone finally got to see you today, what barriers are you actually overcome with them, both on the medical side, but then also on this access to care side? So.
Yeah, I mean, I think the biggest barriers is just they don't have coverage. So they're coming in to see me, and they finally have overcome that internal bias, as Nikki was talking about, where they've quit blaming themselves and acknowledged, I have a disease, I need to get help. And that can be a very hard thing for patients to do, because they've often experienced this bias from the time they were children in their own home. They then see it again with their peers in school, and then they get it in healthcare. Healthcare is actually one of the most common places where patients feel this stigma. So they overcome it, and they come into your office, and then I'm looking at this patient who has obstructive sleep apnea, hypertension, diabetes, and a BMI of, say, 50, which is a pretty common demographic in Georgia. I live in the southeastern part of this country. We have very high obesity rates. We have very limited coverage of medicine, and we still have major gaps in surgical coverage. So either I'm seeing them and they have really bad surgical coverage and their deductible is going to be really high, or they have no medical coverage whatsoever. So if I wanted to put them on a pre-op medication to try to bring their BMI down to make surgery even safer, I can't. Or they have really, really old school policies where they have like a one and done, where if they've ever had any treatment of their obesity, their insurance company now says you can't have any more surgery. Which again, if we did this to cancer patients, there would be riots in the street. There would be outcry of just proportions like you've never heard. If you said, if you get recurrent cancer, you don't get any more surgery. We know that obesity is a chronic, unremitting disease that patients are going to struggle with their entire life. They deserve every opportunity available for them to treat this disease. To say, well, you've already had treatment, back when you were 20, and now that you're 60 and life has happened and other diseases have happened, we're not going to let you have any additional surgery. That is a real struggle right now. I'm also facing issues. A big one for bariatric surgeons right now is so many of these insurance companies are trying to tell us, you can do a bypass, but it has to be outpatient. We're no longer going to pay for you to do that operation on an inpatient setting. But they pay for the cancer patients or the reflux patients that are having the exact same operation. They get reimbursed and paid for an inpatient stay. But because we're doing the exact same operation for obesity, it's outpatient. And that's not fair. I mean, there's no other word for that. It is simply not fair. It is discrimination against our patients. And that is an everyday struggle for us. We cannot afford to jump through all the hoops that the insurance companies put for our patients if we can't collect enough money to support the program. Either take away some of the hoops but again, the baseline is still, we can't make an operation safer than we've already done through the MBSA QIP and all the quality programs. I would argue this is probably one of the the safest operations that you can get. And we're incredibly cost effective, yet we're still being told no. And it's frustrating, but that's an everyday struggle. And it's really frustrating when you tell the patient, this is exactly what you need. And as your medical provider, as someone who has multiple degrees, multiple board exams, I outline your treatment plan for you, and then it gets denied by an insurance company who may or may not have even opened the chart. Some of these are just blanket denials based off of CPT codes. That is incredibly frustrating as a provider, as a surgeon, as a physician, to just have someone arbitrarily deny a patient their claim based off a CPT code. And it happens every day.
Yeah, and I just want to, emphasize what Renee's experience. It runs across the board, counseling, medicines, and surgery. So I've been sought treatment for my obesity for now over 30 years, and not once has my insurance company ever paid for it at any time during those 30 years, right? And that's the reality that most of us who live with this disease live with. And again, why we push so hard on our Medicare system and have to rely on folks like our good friend Parker here to help us move this legislation or regulatory rules through, because the reality is what Medicare does, the rest of insurers follow. So we'll move forward. So Nikki, I'm curious from your perspective, what kind of advice you have or what kind of opportunities you see for people living with obesity to be an advocate, how to advocate around this issue. I know, how did you fall into advocacy? How did you get so passionate about talking about this topic?
Oh, wow. Well, I think that what the thing that changed it for me was to have a supportive environment. I think that within the environment, even before I discovered the OAC, I was in a part of an environment of people who had also had bariatric surgery, and being in that kind of environment where people just sort of get you is really, really empowering. So, if there was someone like me who were, advocating for their own health, I would say, not only don't be afraid to have that conversation with your doctor. I know that, all of society is saying, in some way or another is sort of exhibiting sort of this bias toward obesity that makes you think it's your fault, that you need to do all of these things differently, and you really don't have the right to go over and above and ask for help, but you really do. You have the right to have a conversation with your doctor about it. You have the right for, there to be options for your treatment. And, a lot of times, doctors, hospitals, medical systems do actually have those patient-led or patient support groups where you can just go and talk to other people who get what you're going through. And of course, if you need that education and support and just to learn a little bit more, the OAC is also always available to people.
Thanks for that, Nikki. Parker, I see a couple of questions in the chat that I'm going to reframe for you, that not to put you in awkward spots, but I know your boss had a lot of conversations with the new HHS director. Did you know if the topic of obesity came up and views around that? I know he was dealing with other sensitive issues, but curious if you had any insights to to Mr. Kennedy's views around obesity. So.
Yeah, I mean, I know that, the new secretary has said in the past that he has questions about, the new drugs and kind of the development and their impact. Since he's become secretary, he has not, I don't think, weighed in on how he views those drugs. And so it's one of these things. We'll get a better sense when we see how CMS deals with the finalization of the MA Part D rule.
Thanks for that, Parker. And I think one thing that we've also seen from our friends, or from Mr. Kennedy, was he actually speaks out pretty strongly against bias and stigma. So actually a positive in that case, that he doesn't believe we should stigmatize individuals because of their body weight. He blames the system, right? Probably the food system, but worth acknowledging that part of that conversation. And then Parker, I'll paraphrase this last one for you, but it was another question is the Treat and Reduce Obesity Act on hold until CMS decides on if they will cover the medicines or not? And so I think you shared with that, right? The answer is yes, right? Until that happens, right? So.
Yeah, I think that's going to be kind of the guide for how we want to move the legislation and view the legislation moving forward. But yeah, it is on hold until we figure out how the admin is going to tackle the inclusion of the drugs in the MA Part D rule.
I appreciate that. And then in terms of timing, do you have any instinct as to so that obviously we're still going through the process to get the new administration in place. Does that affect the timing around the admin rules? But usually this rule normally gets work because it's part of the Medicare Advantage rule, right? It usually has a relatively quick timeline for turnaround. But do you have any feel for that? So.
Yeah, I mean, you're right. I think that, I expect the rule to come out sooner than most of the other rules because the insurers are going to need the rule to be finalized before they can start putting together MA plans for the coming year. So, this is always, as you guys know with the history, it's always a difficult year right after an election to come in and do this rule because of the kind of the tight statutory deadline around it. So I'm hopeful that we'll kind of see, soon. I think the other challenge is Dr. Oz has not gone through the process yet. We have not been able to bring him into finance for his confirmation hearing yet, and so not having a CMS administrator in place is also adding to the challenge. Although that's not different than than past years, but it all kind of adds up and makes it just more challenging to get the rule out and have it reflect what the admin wants to see in it.
Thanks. And then one final one for you, Parker, then we'll let you go. But I think there was a question about the fact that you've pointed out that we don't actually have a score for Part B yet. Although some of us have talked to the folks who did that, and they believe that would be relatively modest, but obviously there's a formal process that has to go through. But what is the process for that? Would that happen again after TROA is reintroduced, or what's the next step around that?
Yeah, so in order to get a score, and you have to redo it every Congress, somebody in Congress, either us or I think Congressman Kelly is leading it in the House. We have to formally send legislation over to CMS and request a score. And scores are kind of done as they come in, so you kind of get added to the queue. And so one of the big things that will help us, I think, is CBO prioritizes leadership and committee of jurisdiction requests. And so, our hope is, since Ways and Means has been very active, that they can help us again in terms of telling CBO that it is a priority to get the Part B side done. But I think, you're probably right in those conversations that it will be a very minor score. And I saw in the question that popped up, we did submit the score for Part B last Congress. We didn't get it, and so we have to start the process over again.
Yeah, I know, Parker, and a number of us actually, when our friends at CBO presented some of that data at some public events, including one that you were at, challenged them to say, well, why isn't this included, right? And they sort of said, well, we don't think that was the substantive part of the bill, which we could take as a positive, right? That they mean it's going to be relatively low cost, but obviously that work still has to be done. So
yeah.
Great. Well, I think as we close, I just wanted to share with everybody some of the imagery that we're using to encourage the Trump administration to finalize the CMS rule, improving to access to obesity medicines, and encourage all of you to visit obesitycareweek.org to participate in our action alert, which will send President Trump a letter asking him to commit to care by expanding access to obesity medicines. I also want to encourage all the legislative staff who are participating today to talk to your boss, to weigh in with the administration as well. It is time for us to create access to obesity care. And I want to give a special thanks to our panelists, Dr. Hilton, Nikki, Parker. Thank you so very much for being here. I want to thank all of you for attending and supporting both OAC and Obesity Care Week. Thanks again. Have a great day.